Assalamu alaikum, my dear candidates. How are you all? Hoping all are fine. First, I want to ensure is that my voice is clear, my dear candidates.
Yes, ma'am.
Okay.
Yes,
Thank you,
yes,
doctors.
ma'am.
Thank you.
Yes,
Before
ma'am.
starting my thank you, my dear candidates. Before starting my respiratory session, I want to discuss one or two points regarding the ECG. Though my ECG mock little bit tough, little bit hard for someone it's okay. But the thing is that my ECG PDF and kindly mute by all. My ECG PDF and ECG lecture, if you highlight those, pulmonary embolism S1, Q3, T3, VT is VT, and I was highlights shortly one point. In exam, when you sit in front of computer, you can easily count the square. If it is more than 3 square, it's a VT. Sometimes they mismatch with 0.02 to 0.04. My third session, I was discussing with Dr. Afrin Keka. They keep the value 0.04. So better they'll keep the normal value. But in ECG, if they didn't give, count 3. 3 is all worldwide recognized. More than 3 BT, if below 3 it says BT, that's it. Another confusion question from few candidates personally knocked me regarding the pericarditis, ST elevation. ST elevation all over the lid in ECG. Few question scenario could be presentation, nothing, no need to see even the ECG, just presentation when you read, it's enough for pericarditis, but few scenario can be incomplete, so you have to read the ECG. So that who are facing difficulty to read the ECG, my ECG pericarditis was like that. It's really, is it all lead? Is it only V1 to V3? Is it many candidates can't understand what is that. For them, always see not keywords complex, always see ST. If ST elevated in equal line of the ECG, one square above is ST elevation, that's it. Sometimes they twisted the question. You may say, oh my god, it's not all elevation, it's some elevation is so some are not elevated. No, see, is it elevated more than one small square or not? Actually, for diagnosis of myocardial infarction, V1 to V6 we have to measure, is it more than one small square? If it's okay, same. If for the chest lead it is one small square, for the limb leads 1, 2, 3 AVF, limb lead 1 AVL, V5, V6. For limb lead, we have to see two small square for diagnosis of the for diagnosis of the MI. So best to see if it is one small square above, okay, fine, it's a pericarditis because it's inflammation ongoing. That's why it reveal inflammatory changes. Two question was asked me many candidates personally. So I believe SVT question very common in exam. Inferior wall MI, mitral regurgitation complication with pulmonary edema, very common question in exam, frequently asking. From January to this is ongoing May. Every candidate is facing MI related question. ECG, pulmonary edema. After MR develop pulmonary edema. That's it. Common MR. Rheumatic fever, infective endocarditis related question. Very rare, but they ask from the antibiotic. I already discussed those topics and already posted those images. Okay. So I hope all clear, but even from my ECG PDF and ECG session enough to clear the conception. My 45-day course already all will cover inshallah, and I'll take currently recall test, mock test. This platform is that you will do wrong here, not in exam. So if you do wrong here, I'll correct you, and it will not never wrong in the exam. That is the point here. So if any candidates do wrong more, it's nothing to worry, because you are doing not me, you are correcting you. So still now my previous 4 batch maximum are passing, alhamdulillah, no failing rate. They who are still didn't give the exam, they are knocking why this, they can discuss. So best to correct yourself for explanation. Okay, my respirator system today I'm discussing, though this is the very large session. Try to keep concentration for today's session. So respiratory system, first of all, I want to highlight which are the topics we have to emphasize more for my DHA, MH, heart candidates and my SLE candidates. All are here. Just listen carefully. Common is common. We have to highlight those common topics and we have to mark correctly. That is the point. First of all, bronchitis management and pneumothorax. Very high topics for the exam. Pneumonia management, curve score, curve 65. Okay. And cancer related questions, small cell cancer, squamous cell carcinoma. Second, asthma COPD, they ask stepwise management, how you will manage. And from the pediatric session, tracheomalacia, laryngomalacia, many candidates are solving so good, but best to solve accordingly the ala note, but my session will cover and clear the conception. Kindly mute the mic, my dear candidates. So these are the respiratory part. So we have to highlight those points. Another important advice for my candidates whose exam very near, few candidates exam very near, that we have to correct our answer. Which are we confident? Like if I am confident in pediatrics, so it's easy to correct those questions. If I'm gynecologist, it's easy to correct those gynecologist. If I'm medicine specialist, it's easy to correct those medicine. So even someone practicing from in medicine, some specialist subject like respiratory, cardiologist, so they know more knowledge. So best to correct those questions. When my dear candidates will join, kindly mute the mic. It will be nice because this will be the recorded. So respiratory system highlights and very easy to carry the mark. So bronchiectasis. Bronchiectasis, we know very well, is a permanent dilatation of the airway, secondary to chronic infection or inflammation. Most common organism, Haemophilus influenza and Pseudomonas aeruginosa. So these are the most common organism. Haemophilus influenza and Klebsiella, Streptococcus pneumonia, these are the chronic infective cause. But presentation they ask and they give this picture, my heart candidates. They like and they post many pictures. So drumstick appearance, clubbing presentation, tram lines I'm defining. First of all, presentation. Chronic persistent cough, copious excessive sputum, recurrent respiratory infection. These are the picture. So a patient comes to your hospital with this phenomenon. If they ask, my dear heart candidates and DHA candidates, all candidates also, but the thing is that regarding the tram-line appearance, cyst and ring opacity, drumstick, shape fingers. So If we do examination in hands, we will find out the clubbing. In X-ray, we will find out this tramline, cyst ring capacity. Often it could be normal, but they can give this CT scan. You see, ring appearance, and this is tramline opacity. No need to be worried regarding the is it pulmonary edema, is it infiltration of the chest wall, of the pleura, of the lung cavity and lung lobe. So Tramtech lines thick rings in the presentation of the bronchitis, and we'll find out in the CT scan ring-like appearance and tramtech-like appearance in the X-ray. They will not ask what is that, they will ask that find out your diagnosis. So tram-like appearance in my bronchitis X-ray finding. It's the irreversible dilatation of a small and medium-sized bronchi. So 3-point presentation, chronic respiratory infection, persistent coughing, excessive sputum, X-ray finding, CT scan finding, and common organism, influenza, Haemophilus, Pseudomonas aeruginosa, and Klebsiella. HRCT is, you see, this is the bronchodilatation wall thickening with ground glass opacity. Ground glass opacity for the bronchiectasis. Signs symptoms I already discussed, but for the exam they'll give the 6 months chronic coughing, coughing up large amount of the thick mucus, okay, in every day. Shortness of breath, weight loss, fatigue, fatness, bronchus, they'll give this spasm-like presentation. So it's easy to diagnose. The picture is a bronchiectasis ongoing. So bronchiectasis presentation along with the management, they ask common askings recur frequently asking question in the exam, then how you will manage initially or actually for the definitive management. The presentation picture, fever nicer, don't be confused with TB, cause fever nicer, when you see this presentation more than 6 months and chronic respiratory tract infection, it not goes towards the TB, and it will give another clue that CT scan finding or X-ray finding. Okay, so you have to find out the physical examination. Also, there is a clubbing presentation. So bronchiectasis finding and presentation and management. Management will be that there is a physical training, which least means inspiratory muscle training. Inspiratory muscle training, good evidence. So actually what we do, we say physiological and physiotherapy in chest physiotherapy. So they said it's inspiratory muscle training or chest physiotherapy. Actually in exam, then in option they mark chest physiotherapy, so mark it. Chest physiotherapy will be the answer because it's a good result if you give chest physiotherapy, because there's a copious secretion of the sputum in the lungs. So if you do this physiotherapy, this secretion will come out and patient feel relief. Postural drainage, second step. First step, inspiratory muscle training. Second step, postural drainage. Both are very important point, my dear candidates. See what they are asking. Is it initial? Is it definitive? If your presentation infective but your diagnosis is bronchitis, so infective means they are telling temperature high, respiratory rate high, so it's infective. So you have to give antibiotic for the exacerbation. So first of all, you have to ensure the scenario. Is it bronchitis chronically? So they are asking management, so it will be the chest physiotherapy along with the postural drainage, so it's okay. But is it in my emergency department presentation? They are asking how will manage. So yes, of course we have to add antibiotic. Regarding the vaccination, as is common, Haemophilus influenza, Pseudomonas, so we have to confirm the improve vaccination yearly for the bronchitis. So don't be confused regarding the vaccination. As it is common as COPD emphysema patient, you have to commonly give this vaccination yearly or annually, elderly patient. So you have to make sure management stepwise. Is it infective source of patient come to my hospital, or patient come to my hospital chronic bronchitis, now copious sputum, kindly mute the mic. Excessive copious sputum now come to your hospital. How you will excessive copious sputum? Give physiotherapy. Do postural redress. Now present your hospital with infective source, fever and antibiotic. That's it. Okay. These are the way of management. Asthma related question. We have to know the asthma. Though we know very well, but the asthma they ask actually the life-threatening status and they will give ABG. My dear candidates, ABG interpretation class I will take as like ECG, and we have to be very confident in ABG interpretation because you will find more than 8 to 10 questions from the ABG. Okay, so asthma is a chronic inflammatory disorder of the airway secondary to type 1 hypersensitivity. So type 1 hypersensitivity is also exam question. What kind of hypersensitivity in asthma? Is it type 1, type 2, type 3, type 4? So type 1 hypersensitivity associated with asthma. Symptoms are variable and recurring and manifest as reversible bronchospasm. Another question I want to discuss, it was my from the recall. My dear candidates, don't be confused with COPD asthma. Both are obstructive cause, but kindly see few clue. I always emphasize see the clue. They both present your hospital with bronchi, wheezy. They both present your hospital with bronchospasm. But see the age, see the smoking history. Elderly patient, is it possible to come to your hospital with asthma presentation? No. Elderly patient, chronic smoker patient come to your hospital with though FEV1 and FVC ratio will be the decrease both in both cases because they are the obstructive picture. If you ask me personally how it is not COPD, it's the asthma cause. There is a reversibility on the bronchodilator. There is a possessiveness in the risk factor. So we have to make sure what are the background information. Why it is not COPD, why it is asthma. You have to be confident around that. And I'm giving more clue after this asthma scenario regarding the interpretation. So see the risk factor. Another question and another highlight point, paroxysmal and reversible. Paroxysmal and reversible obstruction of the airway. Okay. Risk factor, it could be the family history of atopy. It is atopy. In dermatology, there is atopic dermatitis. Okay. If any family history of atopy, it means there is a hypersensitivity inherited. Any kind of atopy history or patient itself has atopic dermatitis, so it's enough for being asthma. These are the exam recall I am emphasizing. So atopy history, even it is atopic dermatitis, patient carry. So it's enough for patient come to your hospital with shortness of breath, difficulty in breathing, but the history of the atopic dermatitis is atopic asthma. Recent exam question, DHA exam question. Atopic history, now hospital come with shortness of breath, then you are finding there's a wheezy rhonchus, so it's atopic asthma. Atopic dermatitis is hypersensitivity dermatitis. So antenatal factor, this like the maternal, smoking, viral infection during pregnancy, low birth weight, these are the risk factor for having asthma. But they ask by family inherited along this the smoking history. It could be there. Some they ask from the occupation, occupation related asthma. Exposure, like patient painter, patient work in paints, patient work in the chemical factory in where they inhale chemicals. So these are the air pollutants which cause asthma. These are the hints you have to find out why it is not COPD. Socio-economics of focusing on atopy, I already discussed allergic rhinitis, hay fever, and eczema. These are the points commonly they give in the exam. Asthma also sensitive to the aspirin. So if a patient sensitive to aspirin, so more likely clue is goes favor for the asthma. In asthma, aggravating factor beta blocker, aspirin, and NSAIDs, and they ask by drug cause always. My MOH candidates, they give a long scenario along with the aspirin and NSAIDs taking, now aggravating the bronchial wheeze. Why? Due to the drug cause. They ask indirectly. You have to make sure why this presentation. So presentation, either it is occupation related. What is the occupation? Patient painter. Is it any drug cause recently? What is the drug? Recent knee pain? Patient taking NSAIDs. That's why causing bronchoconstriction. Patient have history of eczema or hay fever. That's it. That is the point. But you have to find and you have to think. After getting the question, no need to be hurried. Take time. Okay. So presentation cough, dyspnea, wheezy, chest tightness as well. So sometimes they present with it worsen at night, early morning, pollen, paste, cold air, perfumes, common exacerbating factor. FEV1 FVC ratio below 0.7 is commonly they give in the exam. So it's obstructive presentation, atopy picture, and in COPD also there will be the bronchoconstriction or obstructive picture. But I said you have to find out the causology. We have to do the spirometry test, pulmonary function test, peak flow diary if each patient is asthma and as occupation related. So peak flow diary will help. In Europe, if patient asthma occupation related, they do reschedule. In another field, same word but another field, no need to be exposed, same chemicals or paints. So they give another is a cost social worker. Social economic support they give them, but in our country or in UAE, they just remember this. We have to follow peak flow diary to response work related or clinically patient asthmatic. So we have to do spirometry test for see the obstruction and peak flow diary. If occupational asthma, peak flow diary initially we can do for find out clinical asthmatic picture, but they ask this question from the occupation related. Okay. So see this to help establish, we have to do the spirometry. After establishing asthma to help determine appropriate time. Appropriate time, is it when you are a painters like, or you are a chemical factory worker. So just you are good when you back in the home. But when you go back in your factory, just you aggravating the symptoms. So to determine the cause, so we have to do this peak flow rate diary. Typical result FEV1, it will be reduced, the peak flow, this spirometry picture, FVC will be normal, and FEV1, FVC both will be below 7. Remember it improves post, this you are finding below 7. If you do bronchodilation, it will be improved. Salbutamol can cause tachycardia, adverse effect, a patient tachycardia and history of asthma. You see, to find out the cause. Okay. So another way, these are the beta blocker cause bronchoconstriction. So scenario, though we know very well the answer, but I want to make sure my candidates are well concentrating on my session. So Dr. Keka is here.
Yes, madam.
Okay. Scenario, this one.
A 29-year patient present to the ED with wheeze, and shortness of breath. He is an asthmatic and hypertensive. His GP has recently changed his medication. The likely causative medication is
So, Dr. Keka, find out the cause. First of all, what are the clue here? Patient hypertensive. Now present your hospital,
beta
shortness of breath. Mhm.
blocker.
Beta blocker. Unfortunate GP given beta blocker drug that causes bronchoconstriction, right?
Yes.
Okay. So beta blocker. Thank you, doctor. Same question, Dr. Keka. Actually, I am asking those exam very near. That's why. Same way, if the patient, in this scenario, same scenario, if the patient recently developed ISD and doctors given aspirin or they didn't give any medication, recently developed ISD or recently developed MI and the few medication added, what are the causology for asthma? Same scenario, just modification. So it will be the asthma associated with due to the aspirin. Same was same scenario, patient taking medication for the knee pain. What are the medication for that? So it's the NSAIDs. Dr. Keka, clear?
Yes, madam.
So we have to remember BAN, beta blocker, aspirin, NSAIDs. Okay. Thank you, doctor. So life-threatening asthma, this is very high yield topics for the exam. Life-threatening asthma. My dear candidates, you have to strongly memorize it because they give many scenario from the life-threatening asthma. They give only cyanosis, they give only hypertension, they give only PF value. So these are the very important picture we have to strongly remember. PF value if below 33% is a severe asthma or life-threatening asthma. Saturation is dropping, oxygen is dropping, carbon dioxide even it could be normal. My dear candidates, very important exam question carbon dioxide related. Hypercapnia and carbon dioxide normal, but carbon dioxide normal but oxygen dropping. Hypoxia, it's due to the asthma. Hypercapnia ongoing, oxygen dropping, all toward is it type 1 respiratory failure or is it type 2 respiratory? So it all goes towards the COPD related complications. So always see the ABG interpretation what they say and they always give a normal value. So COPD related question, commonly asked question, and you have to remember strongly COPD patient if it's type 1 respiratory failure, carbon dioxide is not more than 60, it is type 1 respiratory failure. We have to manage by non-invasive ventilation. Non-invasive ventilation. I'll discuss everything later. If it is more than 60, it's ongoing type 2 respiratory failure. We have to do intubation because we have to secure the airway, we have to give the oxygen, we have to manage this both oxygen and wash out the carbon dioxide. So type 2 respiratory failure. BiPAP CPAP indication no need to be strong recommend. Actually they ask from the BiPAP only type 2 respiratory failure ongoing. It's a type 1 respiratory failure but carbon dioxide only 55. It could be in COPD patient, it could be an acute left ventricular failure patient. So CPAPs, continuous positive pressure ventilation, no need to be very worried because in asthma we don't give any BiPAP CPAP. We only do intubation if oxygen dropping, but carbon dioxide retaining. So always remember COPD we manage type 1 respiratory failure by BiPAP. In CPAP, if carbon dioxide we need to wash out but oxygen is stable, we can give only CPAP. It depends. Just remember in LVF we manage by BiPAP. That's it. I will discuss more about that. So life-threatening asthma, this scenario, this indication, this protocol, just remember saturation, oxygen, carbon dioxide value, cyanosis, existing poor respiratory failure, effort all are goes towards the life-threatening asthma. So just for discussion, though we know very well what are the life-threatening asthma criteria, just I want to discuss example one with Dr. Vizin is here or Dr. Saba. So Dr. Saba Jisan. Dr. Vizin.
Yes, ma'am.
Saba Jisan, example 1.
A 3 years old boy with asthma presents to the A&E with acute attack of wheeze. He is drowsy and has cold periphery. His heart rate is 180, blood pressure BPM. He has intercostal recession and widespread wheeze. What is the most significant feature that show impending respiratory failure?
So impending respiratory failure means going towards the type 1. Going towards the type 1 because it's asthma, right? So
Yes,
asthma
ma'am.
life-threatening picture, I discuss shortly. Just tell me what is the one sign here for impending respiratory failure means life-threatening asthma. What are the signs you are thinking by reading this scenario?
Ma'am, he drowsiness and his peripheries are cold. So,
Drowsiness, whole periphery. So all goes towards
dizziness.
life dizziness. Here, dizziness is the life-threatening picture, right?
Yes, ma'am.
This drowsiness is life-threatening picture. Same way, example 2 read and tell me the one clue for the life-threatening picture.
A 3 years old boy with asthma presents to the AE with acute attack of wheeze. He is cyanotic and has a respiratory rate of 45. His heart rate is 180, and he has intercostal recessions and widespread wheeze. What is the most significant feature that shows impending respiratory failure? Ma'am, according to scenario, there is a cyanotic and cyanosis.
So here, what is the
Is
point towards the life-threatening? It's
impending respiratory failure
the
showing
failure
a
due to showing what?
cyanosis.
Which one? Cyanosis. Cyanosis. Okay, cyanosis. So, doctor, you have to remember this life-threatening criteria: cyanosis, arrhythmia, excitation. They can give the A value. Okay, A value if they give
Okay,
or hypertension if they give, everything is important. Okay, so remember this criteria. Thank you, Dr. Saba. You done well.
thank you, ma'am.
So pneumothorax question very important. Very important question. They ask from the pneumothorax. They ask from the tension pneumothorax, spontaneous pneumothorax. So you have to make sure those questions you have to do correct. So pneumothorax question, they will ask patient sudden accident. Actually, always my strong clue towards the pneumothorax question. Any accidental injury, tension pneumothorax, there will be trachea shifted. There is a dullness on percussion. It goes towards the tension pneumothorax. Okay. So acute respiratory distress, tachypnea, desaturation, jugular venous pressure raising on percussion. There is a hyperresonance and there will be decreased blood pressure, hypertension, airway. There is a diminished breath sound. So diminished breath sound, hypertension, hyperresonance, all goes trachea shifted, all goes towards the tension pneumothorax. But you can ask me, ma'am, why not primary? Why not secondary? These are the questions. I will discuss this point after that, but you have to make sure tension pneumothorax is very common exam question, and the presentation will be there. And after RTA, patient develop this shortness of breath, patient develop with trachea shifted, hyperresonance, hypertension, and we have to do initially needle decompression. Insert large bore cannula in second intercostal space in mid-clavicular line. These are the DHA exam question. What are the space? In which affected area? So second intercostal space in the mid-clavicular line, we have to make sure. Few candidates missed my middle discussion. I was posted PDF and I was discussed asthma, idiopathic pulmonary fibrosis. Those points I'll post images, but somehow the recording were stopped. So no need to be worried because the some part of the recording, if they mismatch, I will discuss later. Because few recording in the middle it was stopped. Okay, so middle part of the respiratory part will be discussed later if anyone faces confusion. So pneumothorax question regarding the needle decompression, we have to make sure each patient RTA or sudden develops after fall develop shortness of breath, we have to give this needle decompression and we have to insert a chest needle, chest drain in middle axillary line in case of chest tube drainage. So when we will do it? First of all, primary spontaneous pneumothorax, secondary spontaneous pneumothorax, we have to understand. I'm posting those scenario. So see, my dear candidates, in general treatment, so size of the pneumothorax is very important. In exam, they give the size rim value. So in X-ray, if rim value below 2 centimeter, we have to keep observation. They give this value. Even after road traffic accident, if rim value below 2 centimeter, trachea will never be shifted. On percussion, there will be never hyperresonance, so it will be mild. It's a mild form of the pneumothorax. So spontaneous pneumothorax for the needle decompression and chest tube drainage, we have to know the rim size. So initially we will give the oxygen, but if rim value more than 2 centimeter, we have to give this needle decompression. Primary pneumothorax, spontaneous pneumothorax, primary means there is no causology, there is no secondary cause for having pneumothorax. Secondary pneumothorax means patient have COPD or patient have asthma, that's why patient develop pneumothorax. So we have to do chest tube drainage. My dear candidates, this is the point you have to clear out, that is it primary pneumothorax or spontaneous pneumothorax. You are asking, ma'am, there is no causology of disease, it's a primary. Yes, it's a primary, but regarding the tension pneumothorax, you have to make sure is it sudden onset or not. If it's sudden onset, we have to make sure needle decompression. If it is sudden without sudden onset, but patient developed pneumothorax sudden, it's a primary cause. We have to give this chest tube. So they'll give this. They'll give those chest extra rim value. Thoracostomy tube. Thoracostomy tube. When I'll give thoracostomy tube, who kindly mute the mic. Who enter my session? Kindly mute the mic. Thoracostomy tube, patient who failed aspiration. So you are trying to do aspiration, but recurrently patient develop spontaneous pneumothorax. So you have to ensure, so recurrent phase in recurrent phase we have to do what? We have to place the thoracostomy tube in recurrent case. Neither chest tube, thoracostomy tube, needle decompression all goes towards patient presentation. If below 2 centimeter, We can do observation. If it is more than 2 centimeter, chest radiograph done, aspiration you have to start. If fail, consider repeat aspiration, intercostal drain we have to give, and then if it is still fail intercostal drain, we have to refer the patient to the surgery. These are the not exam questions. They ask exam secondary pneumothorax, so it's the chest tube. Spontaneous pneumothorax give needle decompression. Primary pneumothorax start chest drainage. That's it. These are the summary. I'll give the algorithm later. Secondary spontaneous pneumothorax. So remember, breathless patient is more than 50. Ream value more than 2 centimeter. So secondary spontaneous pneumothorax, we have to give this intercostal tube. If not try aspiration, so simple aspiration. If succeed, it's okay. If not succeed, we have to keep try on. Okay, and later chest surgeon. It's in recurrent case. Simple aspiration, catheter aspiration, actually primary pneumothorax case. Okay, if it's still not controlling, we have to insert intercostal tube. That's it. Intercostal tube drainage for the secondary pneumothorax, except in patients who are not breathlessness and very small in case. So in this case, we can't give intercostal drainage, but we have to make sure intercostal tube drainage, patient symptomatic, air will be more than 2 centimeter, patient are breathlessness. These are the criteria. We have to do this intercostal drainage tube. Thoracic surgery referral in recurrent case, patient we are trying to aspiration, we are trying to the drainage, but still patient has not patient in breathlessness, so we have to do the thoracic surgery referral, and these are the steps we have to memorize. See the pneumothorax X-ray. This is the ER level. Okay. Pleural effusion, exudate, transudate, I'll discuss later. Before this, after discussion, some important question. So traumatic pneumothorax question, when I post this period, just remember those causal was the traumatic pneumothorax, CT guided biopsy pain, secondary pneumothorax cause asthma, COPD related. I already discussed regarding all details, okay? Just remember, and you have to remember the differential point towards the cardiac tamponade. Cardiac tamponade always muffled heart sound will be there. Never miss this point. Muffled heart sound towards cardiac tamponade, intention pneumothorax, secondary pneumothorax, there will never muffled heart sound. Both JVP high, it could be hypertension present, but never muffled heart sound. So pericardiocentesis, chest tube drainage, so chest tube drainage and needle decompression, it depends, are you understanding the scenario or not. Primary spontaneous pneumothorax, patient presented even in Marfan syndrome patient. Okay, so initially you have to do the chest x-ray. Secondary spontaneous pneumothorax patient, COPD asthma patient. If traumatic pneumothorax, so it's the tension pneumothorax, that's it. So see the trachea shifted, no lung marking, collapsed lung, so see the scenario. Pneumonia. In pneumonia, my dear candidates, remember CARB 65, I'll discuss later, but before that, the commonly even two questions recent candidates were faced. First of all, they asked from the CARB, and second, they asked from the management. So, both important. First, community acquired pneumonia mild form, only temperature, cough, you can do OPD based management. So, in mild form, only amoxicillin. So, if you remember AC is our manomics, moderate form AC, in severe form CC. Coamoxicillin, clarithromycin. So, AC, AC, CC. So, these are the sequence of remembering. It's up to you. You can remember any way, but it was my term AACCC, that's it. Pneumocystis jirovecii pneumonia, always. This question commonly I saw they ask from the heart candidates. They give a HIV related picture and they ask from this co-trimoxazole picture, the management. So co-trimoxazole always for the pneumocystis jirovecii pneumonia, and the saturation will be dropped and there will be the history of the HIV. So this is the way we have to keep our eye. Is it HIV related or no? If patient allergic to penicillin, we can't give AC. We have to switch in the CC, cephalosporin, cephaloxime. So if there's severe sensitivity, even we can't give cephalosporin, cephaloxime. Even we can't give. So clarithromycin should not be the contraindication of the drug they discuss here. What we can give doxycycline option, they give actually recent exam, they give doxycycline severe sensitivity, so we have to avoid this one. Severely severe, so avoid cephalosporin, cephaloxime. Clarithromycin we can't give, patient statin taken, patient have AMI, now develop community acquired pneumonia, so you can't give clarithromycin because they give this rhabdomyolysis picture. This is the drug interaction with statin with clarithromycin. So this drug interaction, patient now taking statin, you can't give clarithromycin. So how we will manage? We have to give doxycycline. Sarcoidosis, I can't say how much it is important, severely important sarcoidosis question. They must ask from this sarcoidosis. They ask from the hilar lymphadenopathy, erythema nodosum question. They ask many way sarcoidosis question. So very important topic, sarcoidosis. Sarcoidosis, remember my dear candidates, is a multi-system disorder. So it's a multi-system. Non-caseating granuloma develop. So presentation you will find out there is erythema nodosum. They'll give a dermatology question from the erythema nodosum. Bilateral hilar lymphadenopathy stages of the X-ray they'll give. Polyarthralgia, hypercalcemia picture. All goes towards the sarcoidosis. Clean cut, nice scenario they give from the sarcoidosis. Sarcoidosis scenario, if patient presented to your hospital with erythema nodosum, fever, polyarthralgia, this all goes towards the sarcoidosis and it's an excellent prognosis. Love-Grace syndrome if it is acute form. But Hartford syndrome, they still didn't ask just for understand this. If it is parotid enlargement, so it's a Hartford syndrome associated with uveitis. But still they didn't ask, just for they asked directly what is the diagnosis, hypercalcemia, hilar lymphadenopathy present. So it's a sarcoidosis. So I'll discuss few questions from my candidates here, though you know very well, and the stages I'll discuss. So this example will be discussed with me. Dr. Aisha is here. Fatima Perry.
Yes, ma'am.
Or yeah, read the question because I'll ask you, then you'll answer me. Read the question.
A 33-year-old previously healthy female developed nodular rash over the shins, pain and swelling on both knees and ankles, and mild fever.
So first of all, what is this name of the rash of the scene?
That is erythema nodosum.
Okay, so what is caused this swelling on both knees and ankles, mild fever, all goes towards for which diagnosis?
It is arthritis.
Okay, arthritis. Okay, what is the diagnosis? Yeah, what is the diagnosis of this patient?
Maybe
Erythema,
the sarcoidosis.
okay, excellent. Sarcoidosis. So, erythema nodosum present, arthritis present, fever presence, right? So,
Yeah.
in X-ray, what you will see? Possibility of having in X-ray what?
Hilar lymphadenopathy.
Hilar lymphadenopathy. Excellent. Bilateral hilar lymphadenopathy. Okay.
Okay.
Okay. Thank you. So, a patient. Thank you, doctor. Fatima. So oral thrush, this question very important. My DHA heart candidate, they give these images and they ask what is the diagnosis. So it's oral candidates, we know very well why. Immunocompromised patient is smoking patient who use corticosteroid but didn't gargle. So who are not doing gargle, they develop this candidiasis picture. So we have to stitch them to good inhaler technique, space a device there, rinse my mouth with water after use, and we have to prescribe oral fluconazole. Exam question, we have to make sure this medication name oral fluconazole we have to give. Same way here, LTU2, if you see this PDF also will be shared, this LTU2 criteria, cyanosis, polycythemia, peripheral edema, when the indication, you can read from there where there were 3 indication only, FFB1, FB ratio only 30%, and there's a hematocrit level, but you remember peripheral edema if there's a cyanosis if there, raised JVP, also these are the criteria. If any of the following, you have to give LTOT. So these are the management of the COPD already I discussed regarding first oxygenation, the nebulization, corticosteroid, if acute form, if coniform, if any infective source, NIF therapy, BiPAP and NIF ventilation, if type 1 respiratory failure, okay. Asthma related pediatric question I'll discuss in my pediatric session. Cancer related question I'll discuss because squamous cell carcinoma related question they ask. Before that, CARB 65 was missed. That's why I just remember. I didn't discuss the CARB 65. Just give me 1 minute. This CARB 65, yeah. CARB 65 question they ask. Many recall they ask CARB 65. So remember, a pneumonia management we have to do scoring. We already discussed man scoring, Chadva score, Hazard score, Timmy score. So remember this CARB 65 score for the pneumonia. So if patient confused, so score 1. If patient's urea more than all criteria, all value they'll give in your scenario. So urea 7 is a 1. Respiratory rate more than 30, so it's a 1. Blood pressure systolic volume below 90, diastolic below 60 is a 1. Age 65. So when we'll do home-based management, patient come to my hospital, I am a doctor. So if I scoring them, it's only 1 or 0. It's a very low risk, no need to hospitalize the patient. We have to counsel the patient, even we can give antibiotic if there's a temperature, that's it. But for the temperature, there is nothing scoring. CARB 1 always OPD basis, outpatient department management. Hospitalized treatment always if it is 2 or more. Either patient need antibiotic or IV form or admission. So we have to remember how we will do this CARB 65. Intensive care assessment, if it is 3 or more, means ICU management. So ICU management we have to do if it is 3 or more. So CARB 65, my dear candidates, if I say CARB 65, so age 65, blood pressure 90/60, respiratory rate more than 30, urea 7, confusion. If 0 to 1 OPD basis, even if no need to give any antibiotic, commonly no need to, you can just keep follow up, that's it. If 2 to 3, 1 to or 2, 1 to 3, that's it. It's a need 2 to 3 need hospitalization, or if need we can give the oral antibiotic, but SDO admission even is it's a 2 to 3 IV antibiotic it on presentation. But if it is more than 3, it's ICU admission. Confusion, patient develop urea high, so renal impairment. So you have to do ICU admission. We have to give IV form antibiotic. So this question will be discussed with me. Example, this one, Dr. is Reza. Dr. Reza is here.
Yes, ma'am.
Dr. Reza, this question you'll do and tell me the scoring.
Okay. 52 years patients presence with productive cough for 12 days. He has a short of breath and fever, and respiratory rate is 25, heart rate is 90, blood pressure is 110 and up 80. His chest X-ray shows right lower consolidations. His lab results are unremarkable, and he has a severe allergy to penicillin. Firstly, his cure score is heart rate is not, respiratory rate is not, blood pressure. The blood pressure is underestimated one. Score is here, and I think it's not show his male or female, and I think the
Is there any
score is
score for
1.
male female, Dr. Reza? Is there any score for male female, Dr. Reza? I didn't know. I don't know. Is there any
Yeah,
score?
score.
If you male, if I say it's a male, what is the score?
Male doesn't get a score, but female one score. If female
I
is
think
one
you
score.
are mismatching with
yeah,
which
with,
is score?
yeah, with
Chadbas. But
Chad,
I am
yeah,
asking carb. Yeah, why? I am asking carb. It's not chad.
yeah,
Don't do this. It's a
yes.
carb. You have to know this carb 65. Tell me, what is carb 65? For C, what? What is C?
What is temperature? C?
No. It's a C means what?
C means
You means
circulation.
what? No. Okay, Dr. Reza, keep here. I am discussing with you. Dr. Pallavi is here. Okay, if Dr. Pallavi is not here, no issue. Dr. Kutsia,
Yes, ma'am.
do you know carb 65 explanation?
Yes, ma'am. C stands for confusion, U for urea, R for respiratory, B for blood pressure, and 65 more than age. 65 stand for age.
Yes. So read this question.
Okay, at 52 years, present with productive cough for 12 days. He has shortness of breath and fever of 39 centigrade. His respiratory rate is 25, heart rate is 90 beats per minute, BP is 110/80. His chest X-ray shows right lower consolidation. His labs are unremarkable. He has severe allergy to penicillin. So score for this scenario is 0 because the BP is stable. The respiratory rate is not more than 30. And also there is no confusion. He only have allergy to penicillin.
Excellent. Well done, Dr.
Yeah.
Kutsia. Excellent. Dr. Reza, are you here?
Yes, ma'am.
So carb 65, you will tell again to me. Dr. Kutsia tell to you and you will tell me again.
Okay, C for confusion, U for urination, respiratory
Urea,
rate.
not urination. It's urea.
Yes, urea. R for respiratory rate, B for blood pressure, and 65 is age, more than 65
Thank you.
years.
Excellent. Thank you. That
Thank
already
you.
you memorize it. It is actually, I always want to be confirmed that my candidates memorize it. So Dr. Kutsia nicely explained. So Dr. Kutsia, how you will manage this case? What you want to do? Only penicillin allergy. So what drug you want to give and how you want to manage?
Okay, so he is allergic to penicillin, so we can give him azithromycin, ciprofloxacin,
Okay.
or
Okay. Azithromycin
we
still
can only give
is the
him oral antibiotics, not
oral
hospitalized.
antibiotics. Okay. It's okay. Excellent. So actually, allergy sensitivity, it depends. Penicillin allergy, no amoxicillin, no amoxiclav. So cephalosporin group. If cephalosporin still severe sensitivity, we have to make sure this doxycycline. If patient take statin, this age patient can take statin due to ISD, we can't give clarithromycin. It causes rhabdomyolysis. But in this scenario, as patient allergy to penicillin, we can give discharge with oral clarithromycin cause patient don't have any history of statin. Clear, Dr. Kutsi and Dr. Reza? For both.
Yes,
I
ma'am.
have to make sure cephalosporin group, but there is nothing. Patient have history of the statin, so I can give discharge only by giving clarithromycin. So all points. Wow, the question come to my exam. All towards if my question tell me patient taking statin, I can't give clarithromycin. I have to give cephalosporin. They didn't give any clue. I have to give only clarithromycin. But if they say patient also sensitive to the cephalosporin, we have to give doxycycline. Okay. Clear all my doctors. I hope all are clear, or my voice is clear or not.
Yes, ma'am.
Okay. Pulmonary embolism question, D-dimer, CTPA, conventional, this already discussed, so I don't want to touch. Just for few query, just make sure initially we'll do CTPA, that's it, and we have to start DOAC-NOAC according to apixaban, rivaroxaban. It depends how patient come to my hospital. I already discussed in my cardiology. I just few ABG interpretation I want to discuss because my mock I'll give few ABG picture. Just my dear candidates, just listen. I'll give short lecture from the ABG interpretation. If a patient's ABG pH value is normal 7.35 to 7.45. Oxygen value 12 to 15 kilopascal. You can write down or you can remember it. That's it. Carbon dioxide value is 35 to 45 and bicarbonate value is 20 to 28. So these are the normal value. Carbon dioxide always makes it's a respiratory problem. Bicarbonate always makes it's a metabolic problem. So when I say the interpretation pH value lowering, it's acidosis. If pH value higher, it's alkalosis. My dear candidates, listen carefully my words. If pH value lowering, it's acidosis. If pH value higher, it's alkalosis. But I have to correlate with my carbon dioxide or bicarbonate value. If carbon dioxide higher, our carbon dioxide value is 35 to 45. If you ask me, ma'am, what about the kilopascal? The kilopascal value will be the 4 to 6. So if it is increasing means higher more than 6 kilopascal, so it's a acidemia. If I say if it is more than 45, it's a ongoing acidosis. So it's a 1 kilopascal value, another is a millimole value. So both we have to remember. If carbon dioxide value more than 6 kilopascal is acidosis, it is compensated by metabolic alkalosis. I'll discuss this explanation. I'll discuss this example little bit later. And if carbon dioxide value is lowering down, it's respiratory alkalosis. So it's compensated by metabolic acidosis. My dear candidates, Remember very well, if bicarbonate below 22, bicarbonate normal value 22 to 28. If it is below 22 but base excess, I have to calculate base excess by Y. I have to calculate by base excess by sodium potassium chloride bicarbonate. The base excess normal value is 10 to 12. So it is below -2, it suggests metabolic acidosis. If it is more than +2, it suggests respiratory acidosis. So we have to know very carefully carbon dioxide value and bicarbonate value, because bicarbonate cause always alkalosis, it could be acid. My exam 4 question from the ABG interpretation. 2 was metabolic, 2 was respiratory side. So if you don't know the ABG interpretation, because you have to remember simple. No need to remember complicated way. How simple? Bicarbonate value. Before example, I want to discuss pH normal value is 7.35 to 7.45. Bicarbonate normal value is 22 to 28. Carbon dioxide normal value is 35 to 45. If pH lowering down, it's acidosis. If carbon dioxide higher, it's acidosis. If bicarbonate lowering down, it's a alkalosis. If bicarbonate higher down, it's a acidosis. Okay, so bicarbonate higher down and lowering down, it's a compensation or not, it depends according to the my scenario. So bicarbonate higher down means it's alkalosis. Bicarbonate lowering down means it's acidosis. Alkalosis or acidosis, it depends up to my presentation. So how they ask? Always strongly remember vomiting and diarrhea question, DHA question, very commonly asking question. It's a paid question. They ask from the diarrhea, it's acidosis. Even you don't know the ABG, but make sure they'll give ABG interpretation. I'll discuss those examples after a little bit later. Just remember, if a patient come to your hospital, I'll discuss my panels. I can't see. Kindly raise the hand, my panels. Okay, I want to see the who are on my panels. Dr. Ikra Sava. Okay, Fatima. Okay. Okay. So pH value, Dr. Saba is here. Dr. Saba is here. Dr.
Yes, ma'am.
Ikra. Dr. Saba. Okay.
Yes.
Tell me what is ongoing here. First of all, doctor, tell me what is this, and what is this. Then tell me, ma'am, I am thinking this. pH value what? 7.2. Is it lowering or highering?
Ma'am, pH value is 7.2. It is low.
Hello? I think Dr. Saba facing any difficulty. Or who can talk with me? Okay, my platform except Saba. There is Dr. Sharma, Nandini Sharma.
Yes, ma'am.
Dr. Sharma, you can mute your echo, background echo, and you can discuss with me.
Yeah, ma'am. Ma'am, the pH is 7.2. So there is an acidic component definitely. But the CO2 levels are like 35 to 45. It's on a bit higher side. But the bicarbs are on a bit lower side. That is 3.30. So I guess this
No, it's a bicarb is 30, means as a normal value is 28 to
okay,
22, 28,
okay.
not 30. Okay. 20 to
Okay,
28,
it's
30.
30.
The bicarbonate higher. It's a bicarbonate higher, carbon dioxide higher. 7.2 is pH lower. So tell me, component, what is ongoing here?
It's respiratory acidosis with compensated Metabolic
metabolic
alkalosis.
alkalosis.
Yes, ma'am. Yes.
Excellent,
Yes, ma'am.
excellent done. First of all,
Thank you,
acidotic
ma'am.
parameter, acidosis parameter, pH lowering, carbon dioxide hiring, it is acidosis, which is compensated by metabolic, right? So, though carbon dioxide within 50, it is a type 1 type or type 2 respiratory failure. Do you know, Dr. Nandini? Is it type 1 or type 2
Yes, ma'am.
respiratory
Yes,
failure?
ma'am.
Yeah, tell me.
It's a type 2 respiratory failure,
Is
ma'am.
it
It's a
no?
type
It's
2
a type
respiratory
two.
failure
No,
because
it's a type 1 because still carbon dioxide didn't cross 60. If it is more than 60, it's type 2.
okay.
If it is within
Okay, ma'am. Okay,
60,
ma'am.
it's a type 1. Okay, thank you. You done
Type
very
1
well.
respiratory failure. Thank
Yeah,
you, ma'am.
yeah. Another candidates for my platform. Yeah. This is the way we have to do perform because if we do wrong here, it will be clear on our doctor. It's Kishore is here. If
Yes,
he
ma'am.
is, tell
Yeah,
me.
I'm here. I am
Okay.
here.
Okay. Dr. Kishore, a patient come to your hospital with severe vomiting,
Mm-hmm.
and you are find out this one. Tell me what is ongoing, and you are emergency doctor. Severe vomiting. Tell me the interpretation and tell me how you will manage.
Okay, ma'am. Severe vomiting. PS is 7.5, and CO3 is 50, and CO2 is 30. Okay. The normal value of PS is 7.3 to 7.45. Here, the PS increases. That means alkalosis. SCO3 is 50. Normal is 22 to
28.
28. That means it is also increased, and CO2 is 30. That means CO2 is normal. This is metabolic acidosis with
How? It's a higher, dear. It's a higher.
it's alkalosis, ma'am.
It's a alkalosis.
Yes, metabolic
It's
alkalosis.
alcohol. Excellent. Compensated by respiratory.
Yes.
Respiratory compulsory. Excellent. Dr. Kishori, you must make sure this is actually my exam question. Vomiting, patient come to your hospital. What is your ABG interpretation? How will manage? So it's a metabolic alkalosis. If I said even you don't know, Dr. Kishori, I said only patient come to your hospital with diarrhea. If you in blind eye just mark acidosis, metabolic acid. I ask you, patient come to your hospital with severe vomiting. It's enough. Even if you don't know ABG interpretation, both question I faced in my exam, even if you don't know ABG interpretation, mark is alkalosis for the vomiting, acidosis for the diarrhea, and type 1 type 2 respiratory failure I already discussed. Clear, Dr.
Yes,
Kishori?
ma'am. Yes, ma'am.
So it's the compensated by respiratory system, right? Respiration is compensated. So how you'll manage?
Oh, manage.
It's a severe vomiting, so we have to do hospitalization. You have to start the fluid management, right?
Yes, ma'am.
Okay. There's no infective source. It could be any food poisoning, it could be anything, but we have to make sure the IV fluid, both combination option were there. So these were not so easy question to me. There's a long scenario and options are long, so you have to make sure it's a metabolic alkalosis along with IV fluid. These were combination of the options. So both combination, if you are the expert enough, I am a GP doctor. I'll start the IV fluid because patient ongoing vomiting. There will be the sign of the dehydration and there is a metabolic alkalosis ongoing. Clear?
Yes, ma'am.
Both question I discussed with Dr. Nandini and you, both very important for exam question. Thank you, doctors.
Okay, ma'am.
Okay. So this question will be discussed with me from Dr. Reza. Dr. Reza is here.
Yes, ma'am.
Dr. Reza, example 3 for you.
Okay. Example 3. A 28 years has been having shortness of breath and for the last 16 hours and is feeling unwell. His lateral blood gas show pH 7.51, PCO2 is 8, normal is more than 10. PaCO2 is 3.1, normal is 6.626. Bicarb also 20, normal is 22 to 26. pH is in high than alkalosis, and the PO2 PO2 also less than normal. PCO2 is less than normal, and bicarb is also less than normal. Then pH increased, but bicarb decreased. Then it must be a respiratory problem, I think. Then it must be respiratory alkalosis and compensate with metabolic respiratory alkalosis with metabolic acidosis compensated.
Excellent.
Thank you
Dr.
very much.
Reza, from my question, why alkalosis? What you see here?
Why alkalosis?
Mhm. What happened?
Because
pH value. What happens?
because the patient has short of breath. Short of breath means
No,
respiratory.
just tell me the pH value. Tell me that, ma'am, these are the interpretation. So that's why it is alkalosis. Tell me that the pH value CO2 is okay. Yeah, tell me.
Because pH is more than 7
Normal.
point. Yes, the more
4,
than
5.
normal. Then yes, 4, 5. Yes,
And then.
and
Which
then
Mhm.
and then in the second step we follow we assess bicarb. The bicarb is when pH is high and bicarb is low, then it must be respiratory, not systemic alkalosis or acidosis. It must be respiratory problem.
No, just Dr. Reza, for you, just remember always pH high. Okay, fine. Bicarbonate low, but pH high, I have to coincide with other complication, other system. It's a carbon dioxide lower down. It's not higher. So carbon
Yes.
dioxide lower down means it's alkalosis. So it's a respiratory alkalosis, which compensated by metabolic acidosis. Clear?
Yes.
So if I ask, this is the exam question, my dear Dr. Reza. If I
Yes.
ask what is the diagnosis, you told me that, ma'am, it's respiratory alkalosis. Tell me one example for respiratory alkalosis where we found commonly respiratory alkalosis. One diagnosis.
One is aspirin toxicity. At the first step, we have metabolic respiratory alkalosis, and then systemic acidosis.
No. My question is not commonly asking question in the exam. One diagnosis for respiratory alkalosis. Anyone know the cause?
Asthma.
Sudden shortness. No. Respiratory alkalosis never.
Never.
Respiratory alkalosis. One example. Sudden.
Okay. Another is anxiety.
No.
Some vomiting.
Anyone? It's not respiratory alkalosis. Vomiting, metabolic alkalosis. One common example for respiratory alkalosis, exam paid question, sudden shortness of breath. Even they did give this example, they didn't ask what is your diagnosis. They asked what is your diagnosis, means it's a pulmonary embolism. You can write it in a note because this is the exam paid question. They always ask asthma, COPD, embolism, MI. As answer as embolism. Asthma, COPD always cause respiratory acidosis. Dr. Reza, for your kind information, kindly write down the note because these are the exam paid question. If you do wrong, it's nothing to say. So asthma, COPD, respiratory related complication always cause acidosis. Embolism itself cause alkalosis. This is exam question. Okay.
Okay.
So see the cause they ask. This is the cause due to the pulmonary embolism. Respiratory alkalosis, see on the pulmonary embolism. Respiratory acidosis we see in the asthma, COPD. In pulmonary embolism, asthma, same scenario, they give low oxygen, low carbon dioxide, bicarbonate with the normal limit. It's the pulmonary embolism. My dear candidates, though I'll give this PDF all, actually sometimes it takes times to download it all in the Excel, so no need to be hurry. Panic attack, you ask me, it could be panic attack by hyperventilation syndrome. Keep on in mind because this is not exam question. It could be alkalosis, it's hyperventilation, but keep in on mind all will be the low. Carbon dioxide is low, bicarbonate within normal limit, oxygen is higher. So oxygen is high. In your term, there's no oxygen higher. So pulmonary embolism, panic attack, it could be the alkalosis, but exam question, panic, pulmonary embolism. Metabolic acidosis, this example very important. Metabolic acidosis and alkalosis, all are the example very important. Just remember strongly. Dr. Donilda is here.
Yeah, yes,
Dr.
ma'am.
Dr.
Yes,
Donilda,
ma'am.
key 26 is for you. You will read this key 26 and you will tell me CARF 65 score.
Okay. A 73-year-old female presents with tiredness, cough, sputum for 2 days, temperature 39. While viewing her labs, you notice a slight increase in serum creatinine. What is the likely diagnosis? Tiredness, cough.
So see, Dr.
Yeah.
Donilda, you know CARF 65? No? Do you know?
Yeah. C for confusion, U for urea, R for respiratory rate, B for BP, and 65 is the age.
So here a CARF first age is 73. So score?
So it's it's one. C is confusion. There is no confusion. Urea temperature or respiratory rate increase in the serum urea. There is an increase in serum creatinine. So
Yeah,
it's
I can
one.
say so. It could be the one. Okay, fine. It could be
Yeah.
one.
Yeah. Respiratory rate. Okay. 2 days. The respiratory rate is not mentioned.
So CARF 65 is what? 2.
2. Yeah. 65 is 2.
So what is the diagnosis? It is what? It's a
Temperature is 39. So it can be infection with pneumonia. Sort
yes,
of
pneumonia.
pneumonia picture.
Pneumonia.
Yeah.
It's a
Chest
pneumonia
pneumonia.
picture. And we do
Yes.
CARF 65 for bronchopneumonia, right?
Yeah. Yes.
For bronchopneumonia. In this case, you will score 2. How you will manage? There is nothing sensitivity here. No sensitivity. It's all are okay.
Antibiotics.
Mm-hmm.
Antibiotics like cephalosporins. Cephalosporins.
There's no hypersensitivity, nothing they said. I said this step. Do you know what is that? AACCC. Do you know?
Temperature is
Anyone?
39.
This is the antibiotic. No, this is the antibiotic I already give. AAC. A for mild. A for mild. AC for moderate. CC for severe. If patient and sensitivity to the penicillin, so I will avoid this AAC. But patient not sensitive. Patient is okay. So this is the 2. So 2 means moderate. So I'll give AC.
Cephaloxime, cephalosporin.
Amoxicillin and
Yeah.
clavulanic acid.
Okay.
Amoxicillin amoxicillin AC, amoxicillin and clavulanic acid, and CC there is a clarithromycin and clavulanic. So AACCC protocol mild, moderate, severe. Azithromycin, I always say, if any sensitivity they remark, we can go for this azithromycin group, but always keep here the option. Always keep here the
Okay.
option I already discussed. Okay, so if there
Okay.
is azithromycin option, there is no amoxicillin aspirin group, but there is sensitivity, we can mark azithromycin later. But if they say patient is like this scenario, there is nothing, no
Okay.
sensitivity, so I can mark AC. Okay.
Okay. Okay. Okay, ma'am.
Oh.
Okay.
You done very nice, nicely present the
Okay.
cases.
Yeah.
Pulmonary
Thank you.
fibrosis already I discussed regarding the IPF and the cold, the drug related and disease related, and presentation would be the dry cough, clubbing, bibasal fine inspiratory crepitation, progressive exertional dyspnea, causology I already restrictive cause, so it could be the cold mineral worker, fibrotic causes, and it will be FEV1, FVC will be the increase, not decrease. Obstructive will be the decrease, in restrictive there will be the increase FEV1, FVC values. So we have to remember this way. So the extensive allergy alveolitis is MOH exam question actually, but remember very well, if anyone, if I need a few question from DHA, 10 to 15 question will be the heart. So best to remember this one, and for heart candidates also. Extensive allergy alveolitis, also known as hypersensitivity pneumonitis. It's called hypersensitivity induced lung damage. So what is the farmer worker? One strong group patient farmer. Saccharospora reactivation. So saccharospora reactivation or this actually remember this Saccharospora rectangula formally Macrospora fani. This is not our headache. This Macrospora fani or whatever Saccharospora reactivula, we have to remember this bird fancy's appearance, avian proteins. Another is a mouse worker, Aspergillus clavitans, and mushroom worker. They give either mouse worker or farmer, bird fancious or mushroom. Three causology or three risk factor we have to keep care on the exam. My MOS candidates remember this thing. Example and presentation. Shortness of breath, dry cough cause this extensive allergic alveolitis. Patient come to your hospital with fever, chronic cough, shortness of breath, and the X-ray finding will be the diffuse micronodular interstitial shadowing, and there will be the lymphocytosis. There is no eosinophilia. Okay. This way we have to remember this extensive allergy alveolitis, X-ray and presentation and diagnosis. No eosinophilia, mouth worker, mushroom worker, bird fancious, these are the causology, and the presentation shortness of breath, dry cough, fever, no eosinophilia, lymphocytosis present, it's the extensive allergy alveolitis. Ensure the test management always steroid. Okay. Lung cancer, very important. Small cell lung cancer, endocrinology, very high DHA heart, and every candidate remember strongly CH. Plasma osmolality will be low, urine osmolality will be higher. It's a CH. So CH will find out the hyponatremia, low serum sodium. It's always associated with small cell lung cancer. It's a paraneoplastic syndrome. In SCTH, buffalo ham appears alkalosis, hypokalemia all goes towards it could be the Cushing. But here another presentation Lambert-Eaton syndrome which causes myasthenia gravis. So strongly remember exam question small cell carcinoma associated CR in which plasma osmolality will be low, urine osmolality will be high, there will be the hypokalemia, there will be the alkalosis. Buffalo ham appearance means patient develop Cushing syndrome due to SCTH independency. So SCTH related tumor, it could be the adrenal cause, it could be the pituitary cause, but I have to know from where SCTH secretion. It's the extra-articular paraneoplastic cause of the small cell carcinoma. That's why patient developing Cushing. This is the malignancy. So these are the way exam pattern of the question small cell carcinoma. I'll post two more questions because it will take time because many questions I have to cover. Today respiratory session will be elder soon. So squamous cell carcinoma is strong important point. Small cell cancer always patient smoker. That's it. Small important point strong. Smoker patient small cell carcinoma, squamous carcinoma, always non-smoker patient. Non-smoker squamous cell carcinoma. Hypercalcemia, hyperplasia, or parathyroid-related secreting tumor, clubbing, all goes towards the squamous cell carcinoma or hypertrophic pulmonary osteoarthropathy patient develop. Another one I want to discuss shortly, just give me 1 minute. My dear candidates, adenocarcinoma most common slow growing, not smoking. This question they ask non-smoking, slow growing, asbestos related. Hypertrophy, pulmonary osteoarthropathy, and bone metastasis can be present. But squamous cell carcinoma most common related to smoking squamous and Horner syndrome, hypercalcemia. I said squamous could be smoker, not couldn't, because few question recently asked they didn't give smoker, they asked non-smoker, but they give this Horner, hypercalcemia, hyperthyroidism. So I was emphasizing those points what they ask in the DHA candidates exam. Cavity, clubbing, central, lat metastasis, pancreas tumor like presentation, Horner, shoulder pain, all goes towards the squamous cell carcinoma. Adenocarcinoma is benign, so non-smoker. But in small cell carcinoma, always CR, ACTS related, Lambert-Eaton syndrome related, superior vena cava obstruction, always endocrine related. Polymyositis, neuropathy, cerebral ataxia, acanthosis nigricans due to the Cushing syndrome. Okay. So small cell carcinoma, remember two things. One, endocrine related, CR, ACTS related, Cushing related, superior vena cava obstruction related, lymph node metastasis obstruction related, squamous not so also this also endocrine related, but they asked by hypercalcemia, hypertrophic pulmonary osteoarthropathy related question, Horner syndrome related question. So this actually I give this images later. Just remember this way that squamous I have remembered is Horner, but they actually give hyperthyroidism, not parathyroidism, hyperthyroidism, hypercalcemia, clubbing, metastasis, pancreas tumor, Horner, along with wasting, small muscle of the hand, small endocrine related CR. Excellently, they ask from the CR from the small cell carcinoma. I'll discuss this question in my mock inshallah soon. So this cancer can cause hilar lymphadenopathy, metastasis, effusion, okay, compression. This metastasis stage is not so no need to remember everything, just shortly. Small cell cancer, initially we have to give chemo radio exam question, non-small cell. If 1 and 3 stages, we can do surgery. In 3B, excision chemo in case of non-small. So non-small surgery or chemo radio in case of stage 3B. Okay. So remember this way, small cell initially chemo radio, if extensive chemo only. These pictures I will post later. Mesothelioma question not they ask commonly, just remember mesothelioma associated with asbestos related patient is asbestos worker, so they develop there's a pleural thickening and we have to do pleurodesis or radio frequency, that's it. Pleural effusion question was my exam question, that's why this exuded transuded along with the ascites they always they ask. I'll give those differentiation later. Clear efficient question, exudate, transudate. Remember the malignancy, TB, pneumonia, both the exudate they ask very and commonly DHA exam question. Transudate, chronic heart failure, all are the ascites related question. Exudate, transudate, okay, they ask from them. Chronic heart failure, nephrotic syndrome, all are the transudate. So causology very important. Respiratory failure classification already discussed regarding the type 1, type 2. Just remember they said without hypercapnia. Just remember till 59 I'll made it type 1 respiratory failure. This is a strong point. And the causology for the type 1 is the pneumonia, lung edema, and type 2 already discussed. It could be any kind of gaseous exchange. So this question interpretation will be discussed with me in this last question today. Madiha Bhatt or
Yes, ma'am.
anyone. Yeah. Discuss this question with me.
40-year-old woman is brought to emergency with chest pain and shortness of breath with the following observation. Heart rate 115 beats per minute, respiratory rate 26 breaths per minute, oxygen saturation 90%, ABG shows PaO2 8, PCO2 3.6, pH 7.5, bicarb 21. What is the type of respiratory failure?
So first of all, correlate. First of all, tell me what type of ABG interpretation it is. Then tell me, ma'am, this is the matter here. Then I am thinking this way. Tell me pH value, right? pH is high.
Hi, it's
right?
alkalosis.
Okay. Bicarbonate is what? It's a low. So it's
Low.
a low. Carbon dioxide 3.6 means what? It's a low.
Low.
Right? So both goes towards where, my dear?
Respiratory alkalosis.
Alkalosis. And this compensated by
Metabolic acidosis.
metabolic acidosis. So already you can ask me, ma'am, this carbon dioxide is not rising. So how I can say what type of interpretation it is? So carbon dioxide, if I say it's a within normal limit, no, only oxygen lowering, right? Oxygen only 8
Yes,
here. Oxygen only 8 here. So if I said accept my theory, only hypoxia, carbon dioxide normal. So what type of respiratory failure it is?
Type 1.
Type 1. And what is the cause? I already discussed with Dr. Reza. What is the cause?
Pulmonary embolism.
Excellent, Dr. Madhya. Excellent done. Thank you, Dr. Madhya. Dr. Hira is here. Last question for today.
Yes, ma'am.
Okay, stay with me. So read this question and answer me.
A 54-year-old presented with productive cough. Sputum was initially yellowish and green, but occasionally with streaks of blood. She has 20 packs yet smoking history. She has post crepitations. X-ray showed patchy ossifications, dull percussion note at lower zone of right lung. There is weight loss. Vital signs are stable. What is the single most likely diagnosis?
First of all, tell me the clue. Yeah, tell me the clue.
Ma'am, he has chronic cough,
Mm-hmm.
And history of smoking.
Mm-hmm.
Uh,
And age is 54.
Age is 54. So, ma'am, it's bronchiectasis.
It is. What are the point towards the bronchiectasis? What is the extra finding?
Ma'am, the first age is 54. Secondly, chronic cough, and
smoking.
And I guess smoking, ma'am.
Smoking, and there's a coarse capitation, extra finding, patchy compulsification, and dull percussion. Yeah, lower zone. Okay, so key 55 for you. Key 55.
Yes, ma'am. 20 years old, stabbed at right hemothorax. BP 100/40, PR 140, heart sounds clearly heard, hyporesonant percussion on right, trachea deviated to the left, next action to be taken.
So what happened here? What happened here? What is the diagnosis?
Ma'am, here it's pneumothorax.
Is it primary, secondary, or
ma'am,
what type of? It's a It's a what type of pneumothorax it is? Anyone?
Me, ma'am, Priscilla.
Who? What type of pneumothorax it is?
Secondary
Tension.
pneumothorax.
Tension.
Tension pneumothorax. But Priscilla, why is there any secondary cause here? No secondary cause. It's a tension pneumothorax.
All right.
Right? Okay. Dr. Hira, is it clear or not?
Yes, ma'am, clear.
So how you will manage? What you will do?
Here we can.
Tension pneumothorax. Strongly I said one thing after step, after RT, after thing, you have to remember it's the tension. That's it. Second, if there is a trachea shifted, okay, fine. So initially, what you'll do, this is a paid exam question. If you even tomorrow, if you go in exam, you'll get the same question. So tell me how you'll manage.
Chest X-ray.
No. How you will
Needle
manage? Next,
decompression.
It's needle
needle, excellent. Who is the needle decompression? Fatima, excellent. Fatima, excellent. Dr. Hira, needle decompression.
Okay.
Okay. Tension pneumothorax, needle decompression. Tension pneumothorax, needle decompression. You have to do. Okay. This is very important exam question. Thank you, my dear candidate.
Thank you, ma'am. The pneumothorax we do chest tube.
Pneumothorax, will you do chest tube? When? I already discussed. When we chest tube, when drainage, where you were on my discussion. Dr. Fatima, when chest tube?
When it's secondary?
Secondary.
Yes, secondary. Secondary.
Even primary, but we don't know the cause, but primary can be cause, but primary can be case, but secondary primary, but the tension pneumothorax always
needle. Okay, ma'am. Thank you, ma'am.
Paid question. Can't do wrong. My MO is this every candidate, even every day they ask this question.
Thank you, ma'am.
Okay. I'll post my PDF, my lecture all. It'll take time, but I hope I'll take tomorrow, inshallah, mock session from the respiratory. If my candidates tell no, ma'am, we want 1 day more, I can take mock from the recall. If my candidates want, no issue for study respiratory system.
No, ma'am, we don't have an issue. You can post it.
Okay, okay, excellent. We'll tomorrow morning, inshallah, respiratory session, and the downloading will be updated soon. Thank you, my dear candidates. It's covered. I covered every highlights point. All will be the downloaded, and tomorrow will be the neurology session, inshallah. Okay. Assalamu alaikum to all.
Thank you, ma'am. Thank you. Thank you, ma'am.
Allah Hafiz. Allah Hafiz.
Allah Hafiz.